This is a case of topical phaco in a NS3 plus grade cataract. I am going to show you the groove and chop technique of topical phacoemulsification. So by now, two side ports have been made 4 clock hours apart, and some intracameral lignocaine has been injected into the anterior chamber to aid in the topical anesthesia. A main port with 2.8 millimeter keratome has been made. The incision should be biplanar or triplanar for it to be self-sealing. Anterior capsule has been stained with 0.6% trypan blue dye, and after 5 to 6 seconds, it is being washed with balanced salt solution. Now we form the chamber with 2% HPMC. I prefer to put some viscoelastic above the cornea to aid in the visualization while doing the rhexis. So now the globe is stabilized with the help of a iris repositor through the left side port, and 5 to 5.5 millimeter continuous curvilinear capsular rhexis is being done with the help of a Utrata forceps. So now the rhexis is complete, and we proceed to do the hydrodissection using a 27 gauge cannula. Hydrodissection is being performed at different clock hours and intermittent tapping of the nucleus, and ensuring that there is a clear fluid wave crossing the posterior part of the nucleus. We rotate the nucleus after the hydrodissection has been complete, just to ensure that there is no corticocapsular adhesion. I prefer to use the modified soft cell technique of Arsenov, that is viscoadaptive substance followed by some viscocohesive substance. So now we introduce the phaco tip into the anterior chamber, and with the help of vacuum, we aspirate some loose superficial cortex that is present there. The nucleus is freely rotating. So now we make a small trench with the help of phaco 1 mode. It has to be only a few millimeters in size, and after the trench is complete, we can shift to phaco 2 mode, get a good hold of the nucleus using the vacuum, and then with the help of a sharp chopper we can do vertical chops. So now I have done multiple vertical chops to divide the nucleus into 4 quadrants. Now we shift to the phaco 3 mode, that is the quadrant mode, and using vacuum we bring the pieces to the tip of the phaco probe, and then after occlusion we apply the phaco energy to emulsify it. In this case, I have kept the parameters as aspiration flow rate is 32, vacuum is 400, and phaco power is 40. By now, half of the nucleus has been emulsified, so this is the third piece. Phaco is always done in bag or in the supracapsular plane, never too close to the endothelium, never in the anterior chamber. And the emulsification procedure should be carried out in the safe mid-pupillary zone. So this is the final piece of the nucleus. While aspirating the final piece, rather emulsifying the final piece, one has to be very careful, because this is the time when most of the surge happens, and if one is not careful, then the phaco tip may injure the posterior capsule and may create a rent. Now the emulsification procedure is complete. We refill the anterior chamber with viscoelastic and proceed to bimanual irrigation and aspiration. The irrigation is through left side port and the aspiration is through the right side port. One can go in a clockwise or anti-clockwise manner. Always better to remove the subincisional cortex first. Now I have changed hands, and irrigation is through right side port and the aspiration is through the left side port to remove the subincisional cortex at 9 o'clock. A bit of posterocapsular polishing is being done with the help of the irrigation and aspiration probes. I prefer to inject the intraocular lens using the hydroimplantation technique. So the irrigation probe is through the left side port and it keeps the bag inflated, chamber formed, and we slowly inject the intraocular lens using the wound assisted technique, ensuring that the leading haptic goes directly into the bag. Then we can dial the trailing haptic using the aspiration probe. Intracameral moxifloxacin has been injected into the antechamber. Now the case is almost complete. Wounds are hydrated using balanced salt solution, ensuring that there is proper wound closure and proper formation of the antechamber. Thank you for watching.